Hi everyone. Welcome to another session on the trials in ARDS. I think so. We've covered most of the topics in the course, as well as the regular sessions in the top class. So this is one of the last classes that we were pending, and we are trying to complete. So this topic, that is the trials in ARDS, is going to be most likely asked in your Viva. Some things are better if you write these evidences in your theory paper if any particular topic is being asked, be it fluid management, use of neuromuscular blockers, etc. Okay, so there have been a lot of
Sorry to
evidences and lot
interrupt
of
you.
studies.
Sorry to interrupt you, sir. Your
Right.
screens are not visible, sir.
Okay, okay. Is it visible now?
No, sir. Your slides are not visible.
Okay, okay, just a minute. Is it visible now?
Yes, sir.
Okay, thank you. So, as I was mentioning, so trials need to be actually added when you need to give a particular answer. If at all they are asking you anything focused on ARDS, be it ventilatory strategies, fluid management, neuromuscular blockers, like I was mentioning earlier, please make sure to add one or two points about the trials. By and large, don't worry, don't think that you need to remember each and every point, that is the number of participants, etc., because it's really difficult to remember each detail. So, without wasting much time, since it's more or less something that you have to revise during your practicals, we'll go into the next thing. The outline of this particular talk would be under the following headings. I would be talking about evidences, with respect to protective lung ventilation, open lung approach, prone positioning, fluid strategy, neuromuscular blockers, steroids, the use of HFOV, nutrition, and ECMO. I'll also be telling in the end about what are the outline of management of any case who walks in with ARDS, and then about the gist of the evidences till present. So, going to protective lung ventilation, the main questions that we usually ask ourselves when the patient comes to the ICU with ARDS is, what is the tidal volume that I need to set? So, do I have to go with a conservative approach or a conventional approach? At this particular time, I think so. There is no ambiguity. We all know very well that we usually go for a conservative approach, that is a lower tidal volume, high PEEP approach, as per a lot of trials. So, this was actually based on a lot of trials which was done from a long time. So, there is pretty much good evidence that lower tidal volumes are safer and have better survival probabilities. So we all know that the diagnosis of ARDS or the definition of ARDS was there way earlier. It started in 1967 by Ashburn and colleagues, and it went on. But until we had a proper definition given to us by the American and the European Consensus Committee way back in '94, there was no wide, universally accepted definition for ARDS. And post that, the first trial which came out in '97 or '98 was the lung protective ventilation itself, which addressed the parameter of tidal volume. Okay, that was by actually Amato et al. He actually titled his paper as "Effect of Protective Ventilatory Strategy on Mortality in Patients with ARDS." So it was a single center study involving just 53 patients. And what he looked at was whether the tidal volume of around 12 ml per kg with the normal carbon dioxide value in the arterial blood gas had any bearing with a patient who was ventilated with a tidal volume of around 6 ml per kg, targeting that the peak inspiratory pressure is less than or equal to 20 centimeters of water. And in this lower tidal volume strategy, they allowed for permissive hypercapnia. The overall result was there was a significant reduction in the 28-day mortality, but there was no change in the discharge criteria. That is, the overall hospital mortality at the time of discharge was not difference between the two groups. Only thing is, they noticed that barotrauma was more commonly seen in patients ventilated with a higher tidal volume, which is very easy to understand. and that was decreased with a lower tidal volume strategy. So based on this, they went on and did the ARMA trial in the year 2000, and this gave us the clear understanding that the lower tidal volume was the way forward. It used the same criteria as of the Amato et al. It compared 12 ml of tidal volume per predicted body weight per kg predicted body weight, and then compared it with 6 ml per kg. The most important thing is when the traditional approach was given, the first time there was a mention about plateau pressures. In 12 ml per kg, the plateau pressure was taken, up to 50 centimeters of water. Probably this was one of the reasons that the patient had barotrauma and associated ventilator-induced lung injury in traditional ventilatory strategies, as compared to a protective tidal volume strategy of 6 ml per kg, wherein the plateau pressure was less than 30 centimeter of water. So this stark difference in tidal volume gave a concept of understanding about ventilator associated lung injury, as well as it made us understand that protective strategies had significant bearing in the reduction of mortality in patients with ARDS. The only problem was this study was terminated early itself because they saw very good results. That might be one of the things that the power of the study would get reduced. But having said that, there have been various, RCTs conducted later on with use of similar ventilatory strategies, and they have seen benefits. Even so, to the point that we are continuing with the same strategy and have seen good results. The plateau pressure is something which came into picture, and then it was taken into consideration while ventilating these patients, and the ARDSnet protocol also looked into these parameters when they were giving us a protocol for managing patients with ARDS. So we talked about 12 ml versus 6 ml. The next thing was, is there a benefit if we can still further reduce the tidal volume, with permissive hypercapnia being accepted as early as in case with Amato et al. So McNamee et al. Published an article in JAMA way as recently as 2021, wherein the study was titled as Effect of Lower Tidal Volume Ventilation Facilitated by ECOR, that is your extracorporeal carbon dioxide removal, with standard care ventilation, wherein they used a lower tidal volume strategy. So, to understand this better, the question was, does lowering tidal volume using ECOR have any improvement in the 90-day all cause mortality? Okay, so they wanted it to reduce it further down. So what they did was they used ECOR for a patient who was being targeted with a tidal volume of around 3 ml per kg predicted body weight, and whenever there was carbon dioxide increasing, they used ECOR for a period of around 48 hours. The maximum duration of ECOR that was allowed to be used was up to 7 days. This they compared with a guideline based mechanical ventilation as per the ARDSnet protocol, that is your 6 ml per kg predicted body weight, and the PEEP titration again based on ARDSnet. What they found was very important. Uh, Reducing the tidal volume below 6 ml per kg, 4 to 6 ml per kg, and the use of ECOR to remove carbon dioxide did not result in the reduction of 90-day mortality. I'll repeat, reduction of the tidal volumes below whatever the conventional treatment at present, that is the lower tidal volume strategy of 6 ml per kg predicted body weight, did not have any bearing. Okay, it actually showed that there was a negative result. Okay, so ECOR plus lower tidal volume is not as of now the standard of care. The other important thing is, apart from this 90-day mortality, they looked into the adverse effects of such physiological states or pathophysiological states that it would set in. That is, when you keep a tidal volume of less than 3 ml per kg or 3 ml per kg, there will be definitely increase in the CO2. What they saw, the cerebral circulation was getting hampered in such patients, with certain incidences of IC bleeds also being seen. So this actually led to the understanding that CO2 retention, despite the use of ECOR, would be detrimental because it will again worsen the inflammatory condition in the patient with ARDS. So again, better to use a 6 ml per kg tidal volume as already given to us by the Amato as well as the ARMA trial. Okay. So, how do we understand this much better? So, for bedside understanding and daily practice, there have been multiple trials, like we told earlier, right? Amato started in 98, again, ArtsNet in 2000. Again, Amato came up with his understanding of tidal volume ventilatory strategies. There was a lung safe trial. And based on these things, there were two things that the ESICM and the SECM came up with. Okay. So understand that an ARDS lung, you can address it in two ways. Okay, one is by the lung size, that is the patient's predicted body weight, and you adjust the tidal volume based on the lung size, or else you adjust the tidal volume to the lung function, that is the compliance, usually the static compliance. So the best practice would be, as per ADSNet protocol, start with a tidal volume of 6 ml per kg predicted body weight. Target and titrate your plateau pressure of less than 30 centimeters of water if you're using a lung size type of a ventilatory strategy. Along with this, also calculate your driving pressure. Try to titrate it between 15 to 18 as much as possible. So 15 to 18 centimeters of water should be okay. But if you have understood all the concepts till now, you have to also factor in the elastic compliance, okay, the resistive compliance. Along with that, the influence of respiratory rate, that is your mechanical power also. So make sure that the mechanical power is also not going up. Probably if you keep it lesser, that would be better. Okay, so that is tailoring your tidal volume to your predicted body weight, that is a lung size. The other way to do it is to look at how your lung functions are based on the stress index. So you should know whether it is concaving or it is bulging. Okay, so based on that parameter on the ventilator, using the stress index, you can construct your tidal volume strategy so as to prevent any ventilator induced lung injury. Okay. So this is by and large about the tidal volume and the ventilation, protective ventilatory strategy in ARDS. Going to the next thing, that is the open lung concept. So till now we were setting about the tidal volume in the ventilator. Next we will talk about association of PEEP and lung recruitment selection strategies on the mortality with patients with ARDS. This is actually a fairly newer trial. Okay, it was published in American Journal of Respiratory Critical Care in 2022. Okay, just 2 years ago. So what they looked at was the response of PEEP at bedside to improve oxygenation, decrease lung elastance, and increased recruitment of the lung volume. It was a network meta-analysis, which was a good thing, with 18 randomized control trials giving a very good sample size of roughly around 4.5, 4,500 patients. And the patients who were involved here were defined as per Berlin's criteria, who had moderate to severe ARDS. What they found was applying higher PEEP without lung recruitment maneuvers was associated with an increased probability of survival as compared to lower PEEP strategy or a higher PEEP with prolonged recruitment maneuvers. Just understand, higher PEEP alone would be sufficient enough based on your FiO2 requirement as per your ARDSNet protocol table to manage these patients with moderate to severe ARDS. Recruitment maneuvers probably might be detrimental. So this is proven beyond doubt after this particular meta-analysis. So how do you understand it better? Just look at this forest plot by the same article. Okay. So this will be a slightly confusing type of a forest plot wherein you see that it's actually moving across the line of no effect. But what you have to look into is what is the comparator which is being used. Okay, when higher PEEP was compared with lower PEEP, it favors the treatment, so it is shifted towards the left. Okay, when higher PEEP was compared with higher PEEP without lung recruitment maneuvers, it favored the comparator, that was just the higher PEEP. Okay. At that time, there was fairly okay results. Few of them are showing there is in between. So overall, I'll be able to tell you in the next slide. Okay, what we see is probability of survival. Okay, that is your posterior probabilities. I'll just put in another table next slide, which will help you understand. So then again, you look at the comparisons, that is the additional comparisons, that is higher peak with prolonged versus brief lung recruitment maneuvers. Okay, so if it was a brief lung recruitment maneuver, it actually favors the comparator. Okay, so one more thing that needs to be seen here is esophageal manometry based adjustment of PREEP. Okay, if you see that, it actually favors the use of a modality like a esophageal monitor for the optimization of the transpulmonary pressure. Okay, so these are the things that we need to understand. So I know it is way confused, but remember here, the only best thing that you can do for an open lung concept is apply higher PEEP without any lung recruitment maneuver. If you have an esophageal manometer to adjust these settings, that would be a little more superior tool in optimizing the ventilatory strategy for that particular patient with moderate to severe ARDS. So, what do I mean by posterior probability? So, forget the forest plot because it was a little confusing. But if you can understand this, the one with the darker shade of blue, that actually gave us a good, benefit, that is up to 99% posterior benefit. That is saying that the patient overall outcome is better. Okay. So, what was the intervention? Higher PEEP without lung recruitment maneuver. What was the reference here? It is the lower PEEP. Correct. Then again, you would see what will happen if you have a brief lung recruitment maneuver. So in lung recruitment maneuver, you will be thinking, okay, prolonged lung recruitment might be detrimental, maybe harmful, but what if I can give a shorter recruitment maneuver? Correct. Probably a side is one thing that you might be thinking of. So what they saw was that was probably more effective than compared to a lower PEEP. Okay, so if you're comparing it with lower PEEP, probably a side maneuver would be better, again giving a good posterior benefit. But at the same time, you can see one more thing here. Okay, so here, if you compare that higher PEEP with brief LRM without LRM, again without LRM is be better. Okay, just the higher PEEP itself would suffice. So this is what I want you to look into. So if you see this particular row, you will see there is a comparison between higher PEEP with brief LRM with lower PEEP. And if you see here, you'll see higher PEEP with brief LRM, but the comparator here is higher PEEP without LRM. So what you should understand is we almost go to this particular row, wherein it would be sufficient just to keep the patient on a higher PEEP for having lower risk of any injury, thereby increasing the probability of survival. So take home is better to ventilate the patient with higher PEEP as per the ARDS-NET protocol without the use of lung recruitment maneuvers. I will show you the next couple of trials which were done prior to this meta-analysis, which will help you understand better. Okay. So we all know about the alveoli, love, and expects trials, which actually looked into the effect of higher versus lower PEEP. What they saw was there was no improvement in survival. Again, here they compared the ratios of FiO2 versus PEEP based on the ARDS-NET protocol. Okay. So here, what we need to understand is there was a limitation wherein there is a discrepancy of the application of the apt FiO2 for a particular type of PEEP. Okay, so that might be one of the limitations which might have been seen here. So at that particular time, one might have argued that, yeah, probably if you recruit the patient better, things would have been better, right? So that is way back in 2004. There were multiple trials after that. That is your Love and Express, which also showed there was no benefit of altering your PEEP strategies. But after getting this particular meta-analysis, it is very clear that a higher PEEP with optimal strategies as per the ArchNet protocol, that is for setting the FiO2, would give you a better result. Okay, so lung recruitment, please remove it from your mind as a better tool because it actually was associated with higher mortality. Okay, so this is the alveoli trial. Okay, it did not show any this survival benefit when higher PEEP was compared to the lower PEEP. Okay. So again, here, what was supposed to be understood is the PEEP was set as per the ArdsNet protocol, but it was limited for the plateau pressure being set as less than 30 centimeters of water. Okay. The other thing was I was talking about the recruitment strategies. We all know about the art trial. It was a multicentric trial, but despite it being multicentric, most of the patients were from the South American continent. So, despite them having multicenter, the other problem was they only could recruit around 500 patients in each arm. But what they saw was lung recruitment with titrated PEEP based on the response increased the 28-day all-cause mortality in patients with moderate to severe ARDS when it was compared to a lower PEEP strategy. Okay, so by all of this, target your PEEP to plateau pressures and your diving pressures. Okay, probably use of driving pressure and plateau pressure is a more safer technique and optimization of your PEEP rather than just setting it based on some table alone. Okay, looking at all of this from your meta-analysis to now, I know that I have mentioned about the use of the ArtsNet table earlier for the optimization, but that is the tool which they used it. Okay, but that can help you guide your ventilatory strategies. But when you're doing so, always look into what is your plateau pressure, what is your driving pressure. At any point in time, if your plateau pressures are going more than 30, be careful. The probability of this patient ending up with villi will be higher. Okay, so this ventilatory strategies of open lung concept were based on these particular trials. Coming to the next most favorite of all, I think so, because this is something that has been shown to have given best results, right? That is one of the positive trials, or one of the earlier positive trials in ARDS, that is prone ventilation. So all of you know about the Proseva trial. I'll not be telling much in detail, but one of the things that we need to know is this was one of the trials which came after two or three earlier trials. Okay, so the concept of baby lung was given to us by Gattinoni et al. Way earlier, but the thing about the shape optimization, all of that came into picture slowly. So when they understood about the nuances about ventilation perfusion, about the VQ mismatch, about the posterior lung recruitability on proning, things came to the fore. And this was proven by Proseva trial. Okay. So they did see that there was a significant reduction in 28-day and 90-day mortality with a number needed to treat as less as 11, I think so. So that was a very significant study. It was so significant that it was stopped in the interim because it would be putting the control group at a higher risk. So that is one of the reasons. It is also used as a limitation of the study. But then again, there have been multiple trials done using the same protocol. And there was an article by the same group, which was published in 2021, which showed that proning did make a difference in the long run as well. The other question was whether reducing the tidal wall, the duration of proning to less than 16 hours would be beneficial because there was a lot of issues seen with prolonged proning, especially it was hampering nursing care and as well as some sort of pressure related issues. So, one of the studies in 2020 pointed out that proning period of around roughly 12 hours was sufficient to show similar benefits as seen with Proseva trial, which was ventilated for up to 16 hours and prone. So this thing is something that I've already discussed with you guys when I've spoken to you about prone ventilation. It all started with Gattinoni in 2001. The only problem at that particular time was the recruitment and the use of tidal volume strategies. They fairly used a larger tidal volume, and the duration of proning was less. That probably would have been the influence on negative outcomes in the earlier trials by Gattinoni and Guerin. Mancebo's trial was the first trial wherein it used a good, timing for proning, that is roughly around 17 hours of proning, and also went towards a fairly conservative approach in tidal volume, roughly around 8. But then again, we might think that there is some overlap between these two. Roughly, it comes to the same amount. Then Tacon et al. And Guerin himself, again in his Proseva trial, that is what I discussed in the previous slide, reduced the tidal volume further to 6 ml per kg, and then they saw that the same results gave better, outcomes both at the 28 days and the 90-day mortality benefit. Okay, so this is something that we need to focus on. So this is one of the first earlier trials which gave us understanding that there is mortality benefit with prone ventilation, especially in moderate to severe ARDS. Okay, so whenever the patient went into that stage of a PF ratio of less than 150, better to prone these patients, and they seem to have better outcomes. Having said all of this, I would also want you to look into the recruitment criteria for the earlier negative trials. If you see closely, they included patients with a PF ratio as less as even 300. That is your mild ARDS patients. So whether the need for this was there is something that was questionable. If you go on in the back front, you might even think like proning is a type of a recruitment. If you see, probably recruiting these patients was detrimental at that particular time because it might have increased the inflammatory processes at that particular time. Having said of all of this, early proning is always the way forward. That will help in better recruitment of the alveoli, and further on, it would prevent worsening of the ARDS. Okay, so remember, proning moderate to severe ARDS, mild ARDS might not help, but yes, if you see the recent trials on HFNO, again there multiple trials on awake proning have shown benefit if the patient requires a flow rate of more than 30 liters per minute and a FiO2 of more than 40 to 50. Okay. Roughly, there also the PF ratios come to mild ARDS. Probably the difference between the two trials, I would suggest or I would think, is probably because of the invasiveness of the ventilatory strategy. So for HFNO, probably yes, the patient is spontaneously breathing there, and that might be one of the beneficial things that we can see in a HFNO based proning, that is self proning, using the SPANK protocol. Okay. Coming to the oxygen targets, so till now we have spoken about tidal volume, we have spoken about PEEP, we have spoken about proning, we have spoken about recruitment maneuvers. Let's talk next about oxygen targets. There have been a lot of other trials in ICU related to oxygen targets, be it in a patient with MI or in a patient with pneumonia or anything per se. But ARDS as the prime focus was not there. Okay, so that was addressed by the LOCO trial in 2020, wherein it was a multicentric randomized controlled trial looking at liberal versus conservative oxygen therapy in patients with ARDS. So the objective was to assess whether the patient with ARDS, uh, a target saturation or a PaO2 on the blood gas between 55 to 70 and a saturation on the monitor between 88 to 92 was better as compared to a liberal oxygen target between a PaO2 of 90 to 105 on the ABG as compared to a saturation on the monitor of more than or equal to 96%. They looked at this looking at the primary outcome being 28-day mortality. Okay, roughly around 200 patients were included, and they took in any patients who received mechanical ventilation for less than 12 hours. Okay, after that, the PF ratio had to be less than 300. Okay, so by definition, any patient with ARDS, that is mild, moderate, and severe, were taken into consideration. The mean minimum amount of PEEP applied for such patients should be roughly around 5 centimeters of water. Okay, along with the basic thing is the patients who were included in this trial, by and large, were based on the Berlin's definition. So they looked at the conservative strategy and the liberal strategy. Okay, so primary outcome, not much of a difference if you see. Okay, So again, the secondary outcome was death in the ICU in the long run, 90-day mortality, and the risk of occurrence of arrhythmias. Fairly, there was some amount of positivity of occurrence of arrhythmias in a patient with a lower oxygen target as compared to the higher oxygen target. So what they saw was among patients with ARDS, early exposure to a conservative oxygen strategy with a PaO2 between 55 70, that is your lower target, did not increases survival at 28 days. Okay, so if you look at the Kaplan-Meier curve from the NEJM article, which is the LOCO2 trial, you can see that the conservative arm actually has a poorer outcome as compared to the liberal arm, especially at the day 28. If you see the comparator, there is no great difference if you do the statistical analysis, but by and large, it did not show any benefit either. Okay, so it would be fair to say that it depends on the patient's comorbidities and oxygen requirement. Probably you need to look at various other parameters like anemia, etc. So we need to do certain trials on this in the long run to understand this better. Okay, there will be two issues that we need to address here. That is whether hyperoxia is inducing any kind of a problem in such patients. Is that what is causing the issue, or the delivery of oxygen when we target a lower strategy is worsening the microvascular circulation, leading to a detrimental outcome. So this is something that we need to understand. So for now, understand that a conservative approach has not shown any mortality benefit. Okay, coming to the ventilatory modes, a lot of trials are there for the use of modes of ventilation, be it your open or the closed loop ventilation. In closed loop ventilation, be it your PRVC, etc. Of lately, even though this ventilatory strategy is more than 2 decades old, there have been more interest about this particular strategy, especially given the recent COVID-19 pandemic. The thing that I want to talk to you about is Zoo's study on APRV. So, early application of airway pressure release ventilation may reduce the duration of mechanical ventilation in patients with ARDS. So, if some question is asked about ventilatory strategies, you can definitely talk about all the things that I have mentioned earlier, be it tidal volume, PEEP, recruitment, etc., and oxygen targets. Along with that, the mode, if you have to talk about, you can talk about closed loop ventilation being a better strategy. For that, you can use APRV as one of your things, to explain it. In that particular point, I would like to make you understand that by and large, APRV is just a modification of a CPAP, wherein we want the patient to have some amount of spontaneous ventilation. Okay, so Zhu et al., having understood this and taking the criteria of Habashi et al. Habashi is the first person who actually gave APRV, the protocol. Okay, there are two particular protocols that they follow for APRV. One of the protocols is given by Habashi et al. So they use that particular protocol, and they included patients over 18 years with ARDS as defined by the Berlin's criteria, and they took less than 48 hours of intubation as the recruitment population. So when they looked at the Kaplan-Meier curves, they found a significant increase in the number of ventilatory-free days, and a significant improvement in the compliance, extubation success, and decreased length of hospital stay in patients who received APRV. Okay, so this is something that is giving a positive outcome. The study was done in 2017. So if you look at the outcomes of APRV in COVID-19 also has been fairly good. Okay, so probably pulmonary type of ARDS patient, the use of APRV has better outcomes as compared to an extrapulmonary ARDS patients who need APRV mode. So that is by and large understanding about the mode of ventilation. APRV, good outcomes. So just remember that. Okay. Fluid management in ARDS, I think so. We know drowning the patient is what are scared. Increase in cumulative balance, insensible losses, resuscitating these patients more or less likely because these patients would be having associated septic shock. So they would be given fluid challenges in the meanwhile based on their hemodynamic parameters. Whether a conservative approach is better as compared to a liberal approach is what they wanted to look into. The choice of crystalloids were also taken into consideration, but unfortunately, most of the trials included only crystalloids. There have been no wide trials on colloids like albumin for its effect on ARDS. There have been subgroup analysis which are present, but by and large, there is no colloid being tested for the effect on mortality in patients with ARDS. So, coming to the trial that we all know about, that is the FACT trial. It was actually published way earlier in 2006. Okay, and that was the time wherein the AECC definition was still in picture. So that particular time, there was some discrepancy about cardiac and non-cardiac cases for the inclusion criteria in the definition of ARDS. So what they looked into the FACT trial was, does conservative fluid challenge, that is a 7-day fluid balance of roughly 136 ml, as compared to a liberal 7-day fluid challenge, which was as high as 6 liters. If you see what was the outcome, they saw that despite the stark difference in the 7-day fluid balance, they did not show any improvement in the 60-day mortality. But having said that, it showed that conservative fluid management actually had better ventilatory free days. If you see, the p value is less than 0.001, okay, for ventilatory free days, as well as the number of ICU stay, days was also lesser in the conservative group as compared to the liberal group. The only issue is with the overall mortality, with the p value being insignificant. So, by this, the take home would be, do not use mortality as the yardstick. I've been mentioning this quite earlier as well. So, we need to look at the overall outcome of the patient. Probably, looking at the point that the ventilator fee days and the number of days spent in the ICU is lesser in conservative strategy. So it's better to keep the patient on the euvolemia side of the fluid balance. That would help the overall outcome in the long run. The probabilities or the limitations of this trial, what they feel is, the mortality could have been due to secondary insults in patients with the conservative strategy pool, probably secondary sepsis, etc. Okay. Coming to the role of neuromuscular blockers in ARDS, we know there are two major trials, that is your Accurasis trial and the ROSE trial. The Accurasis trial was the earlier trial. It was published way earlier in 2010 in NEJM. It was a multicentric study done in France. Over 20 centers were included. It was a randomized control trial which included double blinding. So, what they looked into was patients with severe ARDS, that is moderate to severe, I'm sorry, with a PF ratio of less than 150 were what were included. Roughly, they had to have 48-hour infusion of cisatracurium. Okay. And all these patients received protective lung ventilatory strategies, that is your ARDS net protocol itself was implemented. Most of the parameters were similar in both the groups, that is your placebo group as compared to cisatracurium. They saw that it was a positive trial. It showed that early use of cisatracurium with patients with moderate to severe ARDS improved the 90-day survival. Okay, this is what was seen. Along with this, because it was used just for 48 hours, they also looked at a possibility of occurrence of probably critical illness, neuropathy, or muscle weakness. They found that it was not significant. Okay, so having seen this benefit, similar thing was conducted in the United States, which was also a multicentric trial, which was unblinded, unfortunately, as compared to the blinding done in Accuracy's trial, but it was a randomized control trial. Most of the inclusion criteria was similar to Accuracy's trial, but unfortunately, they could not find the same benefit which was seen in the Accuracy's trial. This was a negative trial. The problem with this was probably one, the Rose trial was actually unblinded as compared to the Accurasis trial. The other issue would be the sedation strategies which was used. So what was done in Accurasis trial was they relied on heavy sedation for patients who were receiving cisatracurium, whereas in patients with the Rose trial, the control group was actually on a lighter sedation. So this they attributed to the negative outcome of the Rose trial. Another understanding of the Accurasis versus Rose trial outcomes are, there was definitely a significant outcome when the PF ratios was less than 120. And when these patients received a neuromuscular blocker, that is a cetracurium, there was definitely an increase in survival benefit. So, by and large, the take home point is whenever the patient is in severe hypoxemia, as defined by the Caricos index, it's a PFN ratio of less than 120, and if there is ventilatory dyssynchrony which cannot be adjusted by your ventilatory adjustments or your sedation, the use of neuromuscular blocker will definitely help in improving the oxygenation, thereby probably improving the survival benefit. Okay, so remember, Rose trial gave a negative outcome, the limitations being the level of sedation, and another limitation being that it was unblinded as compared to Accuracies, which was actually a well structured trial with double blinding being done. Okay, coming to the next important topic, that is the role of steroids in ARDS. A lot of trials have been done way back from 2006, if you see, to 2021. And if you see the subgroup analysis and a lot of trials in sepsis, they also include patients with ARDS, sepsis with septic shock with ARDS. So, therein, a question would arise: will the patient just with ARDS, be benefited with the use of steroids? Again, the etiology of ARDS also should be considered, whether the etiology is pulmonary or extrapulmonary. Two main trials that I want you to look at is Meduri et al. And Villar et al. Okay, Meduri et al. And Villar et al. Villar et al. Is nothing but your DEXA ARDS. Okay, so I'll be discussing these two trials, and I'll also be talking to you just in brief about the etiology of ARDS and the use of steroids. So, by and large, the first positive outcome was, seen with the Meduri et al. Trial in 2007, which was published in Chest. So, what it saw was there was a lower ICU mortality rate, that is 20% as compared to 42%. It also looked at lung injury score. Okay, when there was comparison between steroid versus placebo. This actually was offset by multiple trials later on. Earlier one prior to Meduri et al., that was Steinberg et al., just published in AGM a year before. Okay, so only thing is they found that if the patient was having ARDS as associated shock, there might be benefit, but just ARDS, there was no benefit at all. Tongyo et al. Also published their trial in 2016. Therein, it did not show any mortality benefit. Okay, this actually was negated by a larger trial done by Villar et al. That is your DEXA ARDS trial. Okay, so along with this, the recent article, which was published by Lin et al. In 2021, gave us a further understanding, especially with some amount of patients pulled in from the pandemic of COVID, that patients who received glucocorticoid had a lesser mortality as compared to a patient who received a placebo or did not receive anything at all. Okay, so by and large, yes, steroid use in ARDS has shown to have given better outcomes. Okay, so the earlier trial that I was talking to you about was the Meduri et al. Published in Chest. Okay, it did give a shortened, ICU length of stay as well as the mortality benefit. The drug used at that particular time was methylprednisolone. The only problem at that particular time, which they were attributing to, is incidence of infections, because usually steroids would set in a state of uh, immunosuppression. So that was the major concern that they looked into. And surprisingly, what they found was patients who were on placebo had a higher incidence of infective outcomes as compared to patients who received steroid. If you can see the last line here, 28% of the patients who received placebos had higher incidence of newer infection as compared to 15% in patients who received methylprednisolone. So if there was a risk which was supposed to come forward because of the use of steroids, majorly it would be in the development of neuromuscular weakness or infections. Definitely, we see things on the other end. There was a survival benefit, and the most important question about sepsis was also answered by this trial. Similar things was also seen in the DEXA ARDS trial, okay, wherein they saw that the use of dexamethasone in moderate to severe ARDS definitely reduced the mortality as well as decreased the length of use of mechanical ventilation in patients who received a steroid, that is your dexamethasone. The dose of dexamethasone used was 20 mg IV for 5 days, and they then tapered it to 10 mg over the next 5 days. Okay. Similar, there have been multiple, dosing strategies that they have been using, especially in COVID ARDS also, wherein there have been suggestion of using higher versus lower, and there have been multiple trials which showed that even lower dose of steroid as less as 6 mg per kg per day of dexamethasone would be sufficient enough to have better outcomes as compared to a higher, that is roughly around 10 mg per kg per day or even 20 mg per kg per day. Okay, so if lesser is better, then better to use steroids. But point is, steroid definitely made a good point when it was compared for overall outcome and decreased number of days of ventilation. Coming to a few negative trials, the role of high frequency oscillatory ventilation in ARDS. These are trials which were done actually in the year 2013. This is when Berlin's definition was just out, and people were actually stuck with the management of patients with moderate to severe ARDS. So the Oscillate trial was actually a multicentric randomized control trial. One of the other important things is this included few centers in India as well. They used a Sensormedic 3100B ventilator, wherein the ventilator settings were usually set on a protocol which was followed across all centers. And this was compared to the ArtsNet protocol, okay, that is using your high PEEP and your FiO2 table. So what they saw was there was actually a higher rate of in-hospital mortality in patients who received high frequency oscillatory ventilation. Similar thing was also seen in the Oscar trial, which was actually a multicentric trial done in the UK. So even this did not have a better outcome. But the most important thing here is the definition of ARDS was the Berlin's criteria. That is what you need to understand. Okay. So there is no role for high frequency oscillatory ventilation. Coming to nutrition in ARDS, not much has been done on this aspect. As it is, nutrition is something like a point that multiple trials have been done, but there is no universal tool which is available for either assessment or to understand the way that we have to go forward for the implementation for mortality benefit or reduced length of ICU stay. This is one of the trials which was published in JAMA et al., which looked at what would happen if there was initial trophic feeding versus full enteral feeding in patients with acute lung injury. This was published way back roughly around a decade ago in 2012. So they looked at trophic feeding, which was initiated within 48 hours of diagnosis of acute lung injury or ARDS in patients who required mechanical ventilation. They looked into various parameters like ventilatory free days, 60-day mortality, ICU free days, and association of ventilator associated pneumonias, and also looked at elevated gastric residual volume. What they found out was trophic feeding did not significantly affect ventilatory free days or the occurrence of infectious complications like VAP. Okay, so whatever said and done, it's better to do a subjective global assessment, and based on that, continue with your regular, feeds of the patients, probably by starting with 20 to 25 kilocalories based on the patient's predicted body weight, and then continue so on. Okay, one thing which they noticed was, obviously, because the trophic feeding, the amount of calorie given, that is roughly around 400 kilocalories per day, as compared to 1,300 kilocalories per day in full feeding. The gastric residual volume was obviously lesser in the trophic feeding, but overall, it did not make any difference. So, by and large, the take home in this particular topic, that is nutrition in ARDS, like in any other case in a patient with critical illness, think about starting feeds as early as possible. You need not start by reducing the calorie intake on day one. There have been a lot of suggestion or implications of a carbohydrate reduced diet, etc. But overall, it has not shown to have any implications on the outcomes with patients with ARDS. What they said was, if a carbohydrate rich diet was given, the respiratory quotient would change, and that thereby it would worsen the outcomes. But that has not been seen in any evidence based uh, mm, trial. So, by and large, start your feeds as early as possible. Probably full feeds you can achieve in a day, or, I mean, 2 to 3 days. That should be your target. Coming to the role of ECMO and ARDS, we all know the two trials, the Caesar and the Eolia trial. The Caesar trial was one of the earlier trials that was published, correct? So, coming to the Caesar trial, so what it looked at, whether there was a mortality benefit. So, death and severe disability at 6 months post randomization was the primary outcome. They included all patients with ARDS who had, a PF ratio of, roughly less than 50 mm of Hg of 3 hours, or 80 mm of Hg at around 6 hours, with an arterial pH being less than 7.25, with a PaCO2 of more than 60. They had similar criterias also, but yeah, if patients were on mechanical ventilation for a longer period, probably they were not recruited. They also excluded patients with severe cardiac failure. Probability of malignancy, patients with malignancy was also removed. Okay, so having said that, the overall outcome what they saw in this was not positive. It did not make any difference. That is, the use of ECMO versus conventional treatment did not give any positive outcomes. The limitation here was 25% of the patients in ECMO group did not receive ECMO, and there was no standardized protocol which was given even in the conventional therapy group. So, by and large, the whole design of this study was flawed. So to draw conclusion from this trial would have been bad. So that is one reason. There was another trial done, that is your Eolia trial. The Eolia trial was done in 64 centers across France, which is usually one of the forerunners in the ECMO program. So they looked at patients who received veno-venous ECMO along with conventional ventilatory strategies. The baseline characteristics was matched in both the groups. Okay. Only problem in this was, again, there was no improvement in the 60-day mortality in severe ARDS as compared to a conventional mechanical ventilation. So it was again a negative trial. The other problem was there were still discrepancies in the design. One, majorly, it was an underpowered trial. It did not reach the recruitment for the amount of thing that it was considered to look at, and there was a lot of crossover in between the two groups of patients involved. So that is one of the reasons. Again, there was a major limitation for this trial as well. But having said this, quite recently after the pandemic, early initiation of ECMO, probably the timing of initiation of ECMO matters. And if you have a better recruitability seen, and if you feel that your mechanical power is going up based on these particular precision medicine there might be still evidence in the long run if we see that patients with ECMO, if when required, especially when your plateau pressures are going high, you're stuck with this patient with severe hypoxia and your mechanical power is going high, probably these patients will benefit from ECMO. So, drawing conclusions telling that ECMO is not beneficial based on these two trials would be foolish. And having said that, probably we need larger trials which are more better designed, which have been done in the pandemic period and the post-pandemic era as well, which are showing positive outcomes. So we must wait for newer trials. So if they ask an exam per se, you must mention that both the study designs were flawed. Initially, Caesar trial, there was a huge flaw in the beginning itself. Okay, the recruitment itself was not up to mark. In Eolia trial, there was a high rate of crossover. So that is also one of the things that we need to see. But despite all of these issues, they did not see any outcome in 60-day mortality in patients with ARDS. So that is about ECMO. Coming to other negative trials. So there have been a lot of trials on statins, etc. Your HARP2 trial, the use of simvastatin, whether there was any benefit. It was actually done in 2014 using the AECC criteria. Again, no benefit. Your esophageal pressure guided PEEP, no significant 28-day mortality as compared to the routine ventilator dependent guidelines. Yeah, but again, to use this by and large as a guideline based therapy would not be suggested. Probably you can use other surrogates for calculation of your ventilator parameters. There was another trial looking at beta interferon in the as an anti-inflammatory tool, but that again did not give any better outcomes. There have been many other trials, including your venodilators, etc., or vasodilators. They have not shown any benefit either in management with ARDS. By and large, if you've understood the classes earlier on ARDS, say suppose a patient walks to your ER and then gets diagnosed with ARDS, gets on a ventilator, gets shifted to the ICU. Probably in the first 3 hours when you receive the patient, optimize your patient, probably resuscitate them properly, look into the ventilatory parameters, stratify the severity, whether it is mild, moderate, or severe type of an ARDS. If the patient is still on an NIV, use your HACR score, or if the patient is on your HFNO, use your ROX index. If you're unable to, ventilate these patients and they're going bad, probably it would be wise to put them on invasive mechanical ventilation and thereby initiate your lung protective ventilation as per the ARDS-NET protocol. Go in the protocolized manner, probably roughly 6 ml per kg predicted body weight tidal volume with a plateau pressure targeted less than 30 centimeters of water should what be achieved within a period of 3 to 6 hours time. At this particular time, it would be fair and optimal to get the plateau pressure, driving pressure checked. Okay, and the lung mechanics also has to be calculated. That is your compliance. Look at your ventilator graphics, look for the stress index, and based on that, you can still adjust your tidal volume. If you have done all of this, keep a watch on this patient. Probably, if you have an imaging done, if you have electrical impedance tomography, you can better understand the VQ mismatch in this patients. And if you don't have that, you can still, get a plain CT, look at the involvement of the lung, and then based on your, routine blood gas analysis, if the patient's PF ratios are worsening, that by going less than 150, you can categorize them as moderate to severe ARDS and initiate them on prone positioning. And despite proning the patient, always keep a watch on these patients. If your mechanical power is going up, if your plateau pressures are going up, your driving pressures are going up, despite optimizing fluids, ventilatory strategies, your modes like APRV, etc. If you still feel the patient is unable to get, lung protective ventilation, it would be fair and wise to consider these patients as a patient who would require early initiation of extracorporeal membrane oxygenation, that is your VB ECMO. Uh, The cutoff which they say is like 80 to 120. So if you feel that the patient falls in this criteria, the pH drops to less than 7.25, better to initiate these patients on ECMO. Okay. So this slide would by and large give you the understanding. The color green gives you the fairly good evidence-based practice. Color red is definitely no. The blue, once in blue, is something which you can take as a case by case scenario. So the ones which have definitely showed some benefit is the predicted body weight based tidal volume, that is your 6 ml per kg, protected lung ventilation, driving pressure, proning, increase mortality benefit with the use of steroids, and oxygen targets, roughly keeping a liberal oxygen strategy as compared to a conservative oxygen strategy as seen in the loco trial. Okay. Again, coming to the word on recruitment, you have seen that increased recruitment causes higher mortality. So better to avoid recruitment maneuvers altogether. So wherein if you have to do a recruitment, proning is one method you can still think about. Okay. Coming to fluids and neuromuscular blockers, conservative fluid versus liberal fluid, the FACT trial did not show an overall mortality benefit. But having said that, it definitely did show reduction in number of ventilatory days as well as the length of ICU stay. Okay, so that by that you should understand that conservative fluids is a better way and the way forward in patients with ARDS. Neuromuscular blockers, definitely with a PF ratio of less than 120. If you're seeing that the oxygenation is not up to the mark, there is ventilator dysynchrony, definitely go ahead and use your neuromuscular blockers. Otherwise, routine use of neuromuscular blockers, especially in mild to moderate ARDS, is not beneficial. Uh, APRV mode, I've told you there is a good outcome, but still, yes, it is not the gospel truth. You might have to consider the ventilatory strategy based on the patient's individual characteristics, be it his compliance, be it his involvement of the um, lung parameters, okay, the parenchyma, etc. No role for pulmonary vasodilators, no role for statins. It's very clear, no role for high frequency ventilation. Okay, ECMO, there is still no robust guidelines which have come forth. But having said that, the earlier negative trials were because of poor design. Probably, if there are better design trials which come forward, they will help us understand better. Okay, so whenever you have a feeling that your patient is not doing well despite your evidence-based medicine, and if you feel that the ventilator strategies are failing, probably the last go definitely would be ECMO. Thank you. If there are any other things that you guys want to know, please feel free to reach out in the chat box or in the group in on WhatsApp. Thank you. All the best.